Kia ora tātou, everybody. Bruce Arnold's my name. I'm the director of the Goodfellow Unit, and it's my pleasure to be the coordinator for tonight. So this is going to be a game of two halves. The first half is for Metro Auckland GPs and nurses and pharmacists. From 8:15 onwards, we've got Professor Peter McIntyre, who's based in Dunedin, but he's an honorary professor at the University of Auckland also. We'll be answering general questions about Q&A. So if you've got general questions, leave them till 8:15, otherwise it'll clutter up the inbox. So you have the chat function is turned off, but the Q&A function is turned on. So if you've got a question about vaccine rollout in the Auckland Metro area, put it into the Q&A, and then after 8:15, we'll start taking questions, just general COVID questions. There's always thousands of questions. It's a very fascinating topic, and we seem to be able to, we always have more questions than we can answer. So it's my pleasure tonight to introduce Dr. Joe Bourne. He's a GP from Te Puke, and he's working with the vaccine rollout with the Northern Region Health Coordination Centre, and then he will introduce two other people from the NRHCC. So Joe, over to you, sir.
Kia ora, Bruce, and thank you for everyone that's come online. Called Joe Bourne, taku ingoa, as Bruce has said, and I'm currently seconded to the Ministry of Health, where I'm the general practice lead for the COVID vaccine immunisation programme. I've been here since the end of January, and probably like a number of you feel that I've actually not done my proper job for about 16 months now, as I've been seconded into various roles responding to the COVID pandemic. So I'm just going to pull up a screen now to share my screen, and how we're going to work this is I'm going to just cover a few aspects of the COVID vaccine immunisation programme at a very high level, just to give you some general background. And then we'll hand over to Matt and Leanne, who are going to touch upon part of the onboarding process, which is really particular to general practices and other primary care providers within the Auckland Metro area. But I'm going to stay online, and I know that there may be people from other parts of the country. So if there were any questions about the role of primary care outside of the Auckland Metro, I'm happy to answer those questions if time allows. So the first thing to do is to acknowledge that a lot of primary care is already involved in delivering COVID vaccines to our communities. So many thanks to those of you that are doing that. Well, it takes a while for the first slide to come up. There we go. So as you know, the vaccine that we're using in Aotearoa at the moment is the Pfizer vaccine. We do have pre-purchase agreements that are in place with Janssen, AstraZeneca and Novavax also, and they're still going through their MedSafe approval process. And we are now at the final stages of MedSafe approval of the Janssen vaccine, and we can expect there to be some news about that in the coming month. What is worth noting, though, is that MedSafe's approval of a vaccine does not necessarily bring it straight into the programme, and that there is a cabinet decision to use the vaccine, which also needs to be thought about. And if we think about the size of this programme, which is essentially looking to give 2 doses of vaccine to the best part of 4 million people, adding an additional vaccine to that introduces more complexity. So there will be careful consideration once we have Janssen approved as to how we'll use that within the programme. And the next point on this slide is really touching upon that issue of it's not just about MedSafe granting approval. You'll see the bottom point on this slide where MedSafe has now given provisional approval for the Pfizer vaccine to be used for 2 to 15-year-olds. But the COVID vaccine technical advisory group are still looking at that to ensure that there's no other considerations that we need to make. And then Cabinet will have to approve its use for that age group, and then we'll start rolling it out. And I guess this is just a bit of a caution when you're talking to people about the vaccine and they say, well, is it now available for 12 to 15-year-olds as well? It isn't at this point in the rollout, and we continue to vaccinate only people aged 16 and above. There has been some news recently around the vaccine and whether we have sufficient supplies available to New Zealand, and we are really confident in our supply of Pfizer vaccine, and we know that we have purchasing agreements in place to vaccinate the whole country using just the Pfizer vaccine if that's necessary. They have delivered according to the schedule so far. So we had 1.2 million doses that were arriving up until the end of the quarter just past, and all of those were delivered. And now we have another 4 million doses being delivered between the 1st of July and the end of September. The first of our larger shipments of vaccines arrived at the beginning of this week, so that was excellent, and that was 150,000 doses. And just to put that into context, we've really been receiving between 60 and 80,000 doses per week up until this point. There are 2 shipments worth of 150,000 doses, and then that increases considerably. In the last 2 weeks of July, we're receiving 350,000 doses on both of those deliveries. So this is the point, and this webinar is beautifully timed. This is the point now where all of our district health boards who are charged with commissioning providers to give the vaccine are really looking to increase their capacity to provide vaccines to their communities. Hence, we need general practice, community pharmacy, multi-whole orders to be available to vaccinate. There's a lot of detail here about the storage of the Pfizer vaccine, and I'm not going to go through those points in detail. I guess the main thing just to signal is when we first approved the Pfizer vaccine, that it only had a very short half-life of 5 days at 2 to 8. And when we were looking at this national program, we certainly felt that that was a considerable barrier to having a really distributed model for delivering the vaccine, as we do with other vaccination programs such as flu vaccinations and childhood IMS. Since Pfizer applied for a change in the cold chain requirements, and that's now gone on up to 31 days, although that's considerably shorter than other vaccines we use in New Zealand, it is a big change, and it does mean that we can use a far more distributed model. Hence now the desire to bring on board and utilise the expertise that exists in the community providers to support this programme. Many providers do come to us and talk to us about the vaccinator workforce being a key constraint. And this slide just touches upon the sorts of numbers of vaccinators we believe we need to be able to deliver vaccinations to the population we're looking to reach, and some of the strategies that we're applying. So again, a good reason to bring on primary care to vaccinate is we can utilise those community pharmacists, general practitioners and nursing workforce that already deliver vaccinations, and there is a bespoke training available through IMAC to enable particularly general practitioners to be able to do the training that acknowledges their existing knowledge about vaccinations. The big change that we have developed to support this programme, though, is the introduction of COVID-19 vaccinators. Now, they are people that don't have to have had a health professional degree already. They don't need to be a registered healthcare professional, but it provides a way that other people who wish to become vaccinators can go through an accredited training program so that they can vaccinate within a limited scope. And we've had good conversations with the colleges and nursing unions about this role, and it's really been embraced particularly by Māori providers who see this as a potential legacy of the COVID vaccination program, being able to recruit new people who will have good connections with their communities, who will be able to vaccinate. But at the moment, the scope is very much focused around COVID-19 vaccinators, not adding the diluent and drawing up the vaccine, but purely just giving the vaccinations. This is a live update on where we're at with the COVID program, and I believe the Goodfellow unit will make these slides available to you so you can look at the detail. But this is just to acknowledge that we've now gone past 1.25 million doses administered, and that is getting towards 800,000 people who have had at least one dose, and we're just approaching 500,000 who will be fully vaccinated with this vaccine. And you'll see that the focus to date has really been around group 1, where we're confident we're up to approximately 95% of people who are in that group 1, particularly those working at the border, and then the large number of people from group 2, and many of you will be part of group 2 as people working in healthcare. We've now sent out notifications to people who are in group 3, and you'll see that we're already progressing well into group 3. And we estimate that the number of people within group 3 is somewhere between 1.2 and 1.4 million people. And so there's a real focus on that group now. You'll notice that there's people in group 4 who have already been vaccinated, and that's because from an equity perspective, we're looking to take a whānau approach for people from Māori and Pacifica communities. And so that means that when an older person who is part of group 3 comes to vaccination, they're able to bring their whānau with them when they're being vaccinated, and that explains why we're already going into group 4. And this is just, I'll leave the people to view this slide at their leisure because it's too small for you to see the detail, but essentially this is just confirming the grouped process that we've taken to ensure that we vaccinate those most at risk of catching COVID first of all, and then those who are most at risk of adverse outcomes should they get COVID. Hence the border, then the health workforce, and then into people who are over the age of 65 and people with conditions that make them more vulnerable to COVID. It's worth commenting now that the strategy for when we move into group 4 is we didn't want to open that to everybody in group 4 all at once. So what we're doing is what many other countries are doing around the world, and we're dividing it into age bands. And then people within those age bands will get invited to make a booking as we move through them. Just an acknowledgement that many people will be from a general practice background who are on this webinar, and that's just sharing with you the price per dose fee that we've negotiated that's available to general practices, and you'll note that there's a difference when giving the vaccine in hours and out of hours. A significant development that has gone live at the start of July is that any practice that's commissioned on a price per dose model will be able to make their claims through an automated system within the COVID immunisation register. So you'll not have to generate any invoices that get sent to the ministry. We will just pick up each vaccination that you do, and those payments will be made on a weekly basis. I'm not going to go into the detail now because I want you to have an opportunity to ask questions, but this is really just stressing the importance of our communications to supporting this programme. We continue to do surveys of the population to get an understanding of what their intentions are around vaccination, and we're feeling pretty good about that, because the latest surveys that we've done is that over 80% and getting towards 85% of the population are indicating that they will take up the offer to be immunised with a COVID vaccine when their turn comes. And that has increased a good 10% since the start of the year, when that number was towards the low 70%. And we know that people's appetite for having a vaccine vaccination is very much influenced by their confidence in the programme. So that's me. I see that some questions have been coming through, but I don't know, Bruce, if you want to, I'll stop sharing my screen and you want to help us out with those questions there.
So Joe, there's a few you might like to answer, Joe. One is, why is the whānau approach only applicable to Māori and Pacifica households? Why not all households that have tier three members living at home?
Yeah, so that's a decision that's been made within the Ministry of Health, that from an equity perspective, that was really about reaching Māori and Pacifica. So regardless of conditions that people have, we know that if we look at any statistics in healthcare, Māori and Pacifica do worse. So that was an attempt to make the programme more accessible to that specific community, while still covering off the needs of people who actually have those conditions from other communities.
Just a question here about vaccine doses. Who does decisions around changing the brand of 1 ml syringes? In our vaccination clinic, we changed from brand of syringe in HD, Hawke's Bay, DHB, I think, has greatly affected the number of doses we're able to withdraw from each vial. From consistently withdrawing 7 is now down to 6 doses only. Is that one you can answer?
Yeah, no, that so one, just a shout out to that person that's asked the question, because they're clearly well involved in delivering the programme. So it's an issue that we're made aware of. There are constraints globally with the supply of both syringes and needles, and we have secured enough to be able to support the programme, but the size of the orders that we put in at the start of the year have meant that the companies have supplied batches of syringes that have just come into New Zealand. So we're the only ones with those particular batches, and we're exploring with the manufacturers now why there appears to be an issue with the way the needles are connecting to the top of the syringe. So without going into too much detail now, I guess I just want to reassure that person that we are absolutely aware of it as an issue, that we have IMAC and the clinical team on the programme looking into it. We're drafting guidance now to let vaccination sites know what to do, how to manage it. We're sourcing more needles and syringes so that won't have the problem, and that we are aware that it is influencing the number of doses that you can get from a single vial. But given that the purchase agreements are based on 6 doses a vial rather than 7, that won't affect our overall supply of vaccine.
A couple of questions about payment. Does the after hours payment only start from 8 p.m? And is the pricing the same for vaccination centres as it is for general practice?
So most DHBs will be commissioning in different ways. So the pricing, when you look at community vaccination centres, takes into account their price per dose, but often when they're establishing those centres, they've got other overheads to consider, such as the rental of the buildings, etc. So it's an indication, but isn't exactly how those are calculated. Any provider being brought on will get that discussion on whether you're going to go for a price per dose or a different funding arrangement, and that can be done with the commissioning DHB. Sorry, Bruce, I'm trying to remember the start of the question now.
Immunisation centres get the same payment as GPs.
Yeah, so I think that was what I was touching on, but I remember now the rest of the question, which was related to when after hours kicks in.
Oh, sorry,
so during the week, after hours is considered as outside of 8 p.m. to 8 a.m. to 8 p.m, but on a Friday, that's brought forward. So vaccinations after 5 p.m. are on a Friday, and then all weekend are considered to be after hours vaccinations.
What database does the invitation come from?
So invitations at the moment, DHBs are working with, many of them are working with general practice. to send the invitations through general practice lists, because when it comes to group 3, it's felt that general practice does have as good a list as anybody else. But I know, and Matt or Leanne may touch upon how they've been doing it in the Auckland Metro area, but I know that in Auckland Metro, the DHBs have taken on sending both notifications and invitations from their own databases. When it comes to group 4, the invitations will be sent out nationally because we're working in age bands, and we obviously have access to the NES, National Enrolment Service. We can get off everybody's contact details and their ages, so we will manage that centrally.
Okay, I think we've done enough questions here. Joe, would you like to introduce your 2 colleagues, and then some of these questions maybe may be answered by them?
Absolutely, and I'll stay online as well. So yeah, it's a pleasure to introduce Matt Hannant and Leanne Curtin, who both work for the Northern Regional Health, and I always remember, Coordination Centre. So Matt is the director, was the Director of Strategy and Transformation in the NHS in London before coming to New Zealand in 2017. And his usual job is the General Manager for Primary Care at Counties Manukau DHB, but he's currently the Vaccination Programme Lead for Northern Region Health Coordination Centre. And Leanne Curtin is a Project Manager, and Leanne is currently managing the rollout for primary care providers for the Northern Region Health Coordination Centre, and she's got extensive experience in health programme and project management, mostly in Auckland and Waitemata DHBs. So I will hand over to them, but be available if needed.
Kia ora. Tēnā koutou katoa. Thanks, Joe. Thanks, Bruce. It's a real pleasure to be here tonight and to talk to you all about the work that we're all doing together in Metro Auckland. As Joe said, my name is Matt Hannan. I'm the Program Director for the vaccination program here. And
kia ora koutou. I'm Leanne Curtin, and involved in obviously the rollout from a primary care perspective of the vaccine program.
So we've got a few slides just to take you through, and then be really happy to answer any questions. So just get that going. So I just wanted to start off really with a few highlights in terms of the work, and really acknowledge all the fantastic work that the primary care and general practice pharmacy have been doing over the last 6 months with us as we move through this program of work and towards December. We have now administered just under 460,000 doses in Metro Auckland. Over the weekend, we're anticipating hitting the 500,000 mark, which is a big milestone for us. And across Metro Auckland, we've done about 37% of the total doses in the country, which is about right, given that we're about a third of the population. So that gives us some confidence that we're on track against our production plan. We've established 12 community vaccination centres. So these are essentially sort of brand new centres that are in either commercial premises or repurposed sort of retail spaces that are delivering vaccination predominantly 7 days a week. We're also been working with PHOs and general practice. We've got a process there. We've currently got 33 general practices delivering vaccine and 4 community pharmacies. We're planning to significantly increase that as we go forward over the coming weeks. And at the moment, we're delivering about 8,000 vaccinations per day. So that's about 55,000 a week. As we move into August and towards the beginning of September, that will increase to about 80 to 90,000 per week. So that's all in train, and some of the work that we've achieved so far. As Joe's mentioned, we started the year looking at Group 1, particularly thinking about the border and the managed isolation facilities that we've got in and across Auckland. Group 2 came next, and now we're really into that Group 3 process. Some of those numbers are some of those numbers are quite significant for us in Auckland. So in terms of the people over 65, that's about 200,000 people. And then people with some particular underlying health conditions, again, another 165 to 200,000. As we were thinking about that equity approach in Group 2, we were really focused on older Māori and Pacific people and their whānau. And again, that continues to be a priority for us as we think about and are working through Group 3. Across Metro Auckland, it's really been about establishing a network of vaccination centres and really thinking about accessibility and acceptability to the community. So there'll be a wide range of settings already. We have a number of the larger centres, as I said. Some of those are run by the DHBs, some are run by providers. So we have a number of Māori-led and Pacific provider-led large community sites. We will and have a large number of general practices operating and providing vaccination both to their enrolled population but also to non-enrolled people. We've also got community pharmacy. We're planning on having a significant number, over 50 community pharmacies providing services. We'll also be providing mobile and outreach services and going into and onto various community settings. We've got large mass vaccination events planned across the city. So these will be at large stadiums, planning on looking at sort of anywhere between 5,000 to 10,000 people over a weekend. Looking at pop-ups and then also working with the ministry about workplace. So really it is about having quite a broad portfolio of options for people and ensuring that people, even if they're living in remote rural areas, also have access to services, perhaps through those pop-up channels as well. So this is just a quick summary of where we're at currently. You can see there's a wide range of sites already up and running across the 3 DHBs. I won't go into all of those now, but you can see that most of the sites are capable of doing hundreds of vaccines per day. The larger sites getting up to 900 to 1,000 in a single day. And that's we will be adding another few sites on. So we've got Silverdale coming online in August, and we've also got another site in Epsom about to open in mid-July as well. And then that sort of brings us probably to the final point in those larger sites, and then there'll be lots more work with general practice and pharmacy as we go forward. And as I mentioned, we've already got a good distribution across the Metro Auckland. The focus initially was on East and South Auckland, especially given the cabinet sequencing framework, and now really looking to ramp up and have more than probably half of our general practices across Metro Auckland providing vaccination. So as I mentioned, Group 3's well underway for us in Metro Auckland. It's a big group, as Joe mentioned, nationally, but for us here in Auckland, we've got 425,000 people at least. We have already issued a significant number of invitations. So that's to Māori Pacific, older Māori and Pacific, and the opportunity to bring and take a whānau-based approach and bring whānau in for vaccination as well. We've invited all people who are over 65 have received an invitation across Metro Auckland, and we're just moving into the remainder of Group 3, which is people with underlying health conditions, people living with disabilities, and other vulnerable groups such as people experiencing homelessness. So that's a big piece of work for us that's underway at the moment. We're really pleased that recently we migrated onto the national booking system. So this is brings us in line with that strategy that Joe was talking about. We just went through a big migration process, which went really smoothly. The new system sets us up well for that go live at the end of July for all of popular for the group 4, and thinking about that process. We can and are continuing to send invitations through that process, and we've got lots of information online on our website about where people can access vaccination. We have received a number of queries. We sent out alerts to everyone in Metro Auckland who would be eligible under Group 3 as part of the underlying health conditions. And I think it's fair to say we've got a bit of feedback there from people who perhaps didn't consider themselves to be in that group. So we're just doing a bit of work at the moment with the ministry to provide information to people to sort of reassure them that they are eligible and that we would encourage them to make a booking. We're also, and there are 28 specific health conditions that are being used to create that database, and that database is sort of a number of information sources brought together in terms of hospital data and prescription information. We've just put the conditions here because we thought that might be helpful for people and informative. And again, I believe these slides will be shared so people can look through that when they've got a bit more time. Other eligible people within that are people with disabilities and their carers. We've already started to do some work with some of the residential providers. That will be an outreach model. We're also supporting people to come into vaccination centres and creating the right environment for there. We've done accessibility audits across all of our big sites, and we're just working through the recommendations of that. We're doing a lot of work with people experiencing homelessness as well, and again that's going to be a combination of an outreach model but also supporting organisations and charities that help people experiencing homelessness to access services through some of our larger sites, and some general practices that particularly have good and strong relationships with people experiencing homelessness. We're also making sure that we do a lot of work to make this accessible, so we're not just relying on email alerts and text messages. We are doing outbound calling through our helpline. We're sending letters to people. We will putting adverts into the paper, and we'll be doing lots of social media and other bits and pieces just to really raise awareness and make sure that everyone who's in that group 3 really does sort of take the opportunity to get a booking now. We are pleased that the sites and the centres are all busy and got lots of strong bookings, but there are bookings available in sort of 2 to 3 weeks time at most of our sites. I'm just going to hand over to Leanne, who's going to give a little bit of information about the particular work that we're doing with general practice, and then I'll just finish off.
Sure. I work specifically with general practices, and I've got colleagues leading this program also for community pharmacies, but the onboarding process is quite similar. Basically, first there's an expression of interest process, and so when I say that, it's really just for general practices is just making your interest available to PHOs who we're working really closely with. And then basically we're working in partnership with the PHOs here. There's 7 of them in the Metro Auckland region. So we collectively have a selection process, and we have criteria whereby we look at the practices who have put their hands up and look at who we're going to select. And the only reason we have to do that is obviously we've been overwhelmed with interest, which is fantastic that the sector are so keen to be involved, but we do have to have this selection criteria. So basically equity is the foremost consideration. We look at the population of the practice in terms of enrolled, Māori Pacific, high needs. We look at the area the practice is in terms of the demographics of it. We also look at that in conjunction with the geography. So where are the other sites? So we want to obviously ensure there's equitable access across the Metro Auckland area. And also site readiness, so because we know that there's such keen interest, we want to make sure that if practices put their hands up, we're all ready to go and we can work with them as fast as possible. So in terms of the onboarding process, prior to the clinical check, if you like, there's basically just 5 stages. We need the site to be set up as a facility so they can receive vaccine. The staff obviously have to complete the IMAC training that Joe alluded to earlier. that's been specifically designed for primary care providers with previous experience of vaccination, a wealth of experience of vaccination. And then the practice needs to gain access to the CIR, which is the COVID immunisation register, which actually one of its key functions is managing the vaccination process and recording it, so that data is sucked up and in the system, so it can be transferred to the PMS systems. And so the other thing we're asking practices for is site configuration information, so that when we're ready for the next phase of rolling out the national booking system, we can actually do that in conjunction with primary care. So at the moment, our community sites have been onboarded onto the national booking system, and the next phase is really working with our primary care providers to get that set up. So we're collecting that configuration information now, so we don't have to go back to them retrospectively. And then the other thing we've set up is an automated portal, so that providers can just automatically on an online basis order consumables, collateral that they need, and so that it can be delivered directly to the site. So then they can all be set up to go, basically. But there is a clinical quality assurance process, and so basically we have a clinical team that goes in and just looks at the practice and makes sure that it's all in line with making sure the cold chain is all set up, and etc. Now, what we're trying to do is work really closely with our primary care partners to streamline that process. We acknowledge that originally, we were most probably a little bit cautious, but we've learned a lot from the first cohort of practices that went through this program. And so now we feel that there's real need to actually streamline it so we can get the program moving a lot quicker, and so we can have a more distributed model, which is what we're working very hard to achieve now. And so basically, once we've completed, a practice has completed the clinical quality assurance process, the site goes live, and so that's usually basically the same day or the next day. It's a very quick turnaround process, and then practices are generally vaccinating patients the next day, which is fantastic. So I just thought this would be useful. I know that Matt showed a graph before, but this is specifically our general practice sites, and I just think it's great to see that, as well as obviously equity in terms of Māori Pacific, we also looked at equity in terms of rurality and isolation when we selected the initial bunch of practices. So you can see that we have got vaccinating sites way out here on Great Barrier Island. We've got them in Waiheke, up in Wellsford, and down in Waiuku. So again, really grateful for those practices that stepped up, and you can see the breadth from a geographical perspective. So in terms of our next step, as I said, we're working with the PHOs to streamline the clinical quality assurance process. Really appreciate the support that we're getting to do this from the vaccination, immunisation coordinators within PHOs, because they're sharing their experience with us to get this moving. And the other thing we're doing is obviously there's looking at other ways to streamline the process. There's going to be a new ministry-led portal which will automate the vaccine ordering process shortly. And also, as I said earlier, we are looking to onboard practices to the national booking system, which will enable them to much more efficiently vaccinate non-enrolled or non-registered patients, because primarily they're working with their enrolled populations at the moment, many of them.
I'll just briefly just summarise the last few slides, wanting to make time for questions. So we've been doing a lot of work with our aged residential care partners. We have been, and to all sites across Metro Auckland, there's about 181 facilities, and we will have finished offering second doses to all of those sites by the mid to late July. So that's a really great achievement for us in terms of getting that vulnerable group vaccinated, and then those teams, those outreach teams, will be able to move into the community, and we've already started thinking about pop-ups and mobile sites and where those are going to be located. As I mentioned, equities at the forefront of everything that we do, really about prioritising Māori and their whānau. We do have 5 of our large community sites of the 12 are Māori-led. So that's Henderson, Manurewa, Marae, Pukekohe, Tamaki, which is Ngāti Whātua Araraki, and then the Takanini site, which is run by the Whanaora Clinic, so the Whanaora organisation. So that's really been a really important part to us and an amazing response from the community. We're doing more outreach, so marae-based hui. There'll be lots of iwi-led activity and provider-led engagement. As I mentioned, we're going to be getting into that pop-up space soon, having mobile units. We've already done marae-based vaccination events and have vaccinated over 25,000 Māori across the northern region. Pacific, again, we've got 2 of our large sites are led by a consortium of our Pacific providers, which again has been a really great response from the leadership in that community. At the Otara and Westgate, and those sites are very popular and very busy. There've been a lot of work through community groups such as churches, a lot of outreach programs, and bringing groups into those large sites to receive vaccination together. We've done a lot of language-specific engagement and materials, really sort of partnering with Pacific comms specialists, and again thinking about those pop-up events, church-based events, and the like. So just very quickly, we're obviously focused on the group 3, just getting all the reminders out to everyone, getting the last invitations out to people with underlying health conditions, and then really thinking about preparing for group 4 and ramping up our capacity across general practice and primary care. Community pharmacy again is going to be another really important part of the accessibility here for the community, and then we'll be ready to that jump off into the beginning of group 4 at the end of the month. And I think thank you very much everyone for your time. There's information about the website there that you can get more information, and that's really it from us, so thank you very much.
Lovely, thanks Matt and Leanne. So high praise from somebody saying amazed at how much you've been doing, so a high five from one of the audience. My question is, if GPs are going to be sending out invites and their invites are going to be coming out centrally, is there a risk that patients might get dual invitations and then be a bit confused as to what to do?
We do try to, well, in all of our comms material, we sort of make it clear that if you've received 2 invites, then, you know, that's not a bad thing, and you get to maybe choose to go to your local GP or to one of the sites that's available on the national booking system. So, but we do try and avoid that duplication if we can by being you know, working across the databases that we've got, but otherwise we do try to make it sort of clear for people that if you've received an invitation twice and you've already been vaccinated, perhaps then, you know, either ignore it or choose which way you want to go.
I know when I got mine, I got an email first and then one say, can you confirm you're coming? And that was quite reassuring because I knew I was going to drive across town and get it. Is that how it's going to go?
Yeah, once someone's got a booking, then the national booking system and the booking system we had before sends them a confirmation email, I think a day or 2 beforehand, just confirming their appointment and giving them some information about coming.
So I got a question from Joan Ingram there about, she couldn't see if people living with HIV was on your list of high-risk groups, and I couldn't see it. I had to look at the slides, maybe something that's worth adding there.
Yep,
that would be a high-risk group.
Yes, thank you for that. So we'll take that away.
Good feedback. And Joe's busy answering questions, which is good. So I'm just having to check through here. Okay, that one's been done.
There is one, Bruce, just about that I started to type, but it might get a bit long. Just asking around proof of vaccination.
Right, the passport.
Yeah, so the current status is that internationally countries are still working through what is going to be accepted globally to enable people to travel to those areas where they are going to be checking vaccination status. At the moment, we have an email system where people have to email into the ministry, and then they run a report off CIR to provide that as proof to people, and that's the sort of standard. We know that very often what people will do is they will present to their general practitioner and ask them to print something out that confirms their vaccination status, but internationally there are no sort of standards around that. So that's what we're doing at the moment, and I'll make sure that the notes that go out from here sort of provide details of the email address to send to if you need that proof of vaccination. But what is in development now is a customer channel which will allow people to receive that electronically if they're unable to do so. We'll still have to provide a paper system too, but a large number of people will be able to have it, so you'll carry it on your device.
I've pasted my 2 ones into the back of my passport, so I don't know whether that will be suitable, but I realise I'm going to need it someday, so whether we can encourage people to do that, but I guess most people won't necessarily do that. So the slides are going to be available later. And Joe, you referred to a webinar at 11 o'clock on Thursdays. Is that a recorded webinar?
Yeah, so we do a webinar every fortnight, and it's really aimed at primary and community providers. So I'll make sure that the details of that are included, and it is also recorded, so people can look at that, and they could even look through the previous ones. And then every other week we produce a newsletter which gives an update on key developments within the programme. So I'll make sure that the instructions on how to sign up for those 2 things are included with the notes that get sent out from the Goodfellow unit.
Yep. So our digital master IT guy will send out an email to all the people who are, and we've had 800 people odd sign up for tonight, send out an email with that information on it. So we're going into the second half now. So I'd just like to thank Matt and Leanne. I think you're going to stay around for questions, as will Joe. And Peter, do you want to show us yourself? So nice to see you, Peter. So
Peter
McIntyre is a paediatrician, academic paediatrician based in Otago. He's a professor there. He was recently made an honorary professor at the University of Auckland. So we're very glad to have you as an honorary professor in our university, Peter. And so for this part, these are general questions about COVID. There was a question a bit earlier about, are we going to get herd immunity? Do you want to maybe start with that, Peter?
Yes. Well, I don't know if I was prevailed upon to write a piece to try and explain this. That was in New Zealand Doctor quite recently. I think I'm not sure if it's the most recent issue, but I don't know how comprehensible that was. But I tried to make the point in that article that there is quite a bit of confusion about herd immunity and what it means, and I think some of the confusion with respect to COVID is the idea that COVID could somehow be like measles, and if we just got to a high enough threshold, we'd never have any more, and we'd have some sort of, force field around New Zealand that'd stop any getting in. And unfortunately, I don't think it's really quite like that. I mean, no one's ever really talked about herd immunity in that sense for influenza, although you do get herd immunity with influenza when there's good evidence that, situations like you have vaccinated communities versus unvaccinated, or households with vaccinated children versus others, etc., that you do get herd immunity that's useful for influenza, but you don't get anything that approaches no influenza. And I think with COVID it'll be just as tough, particularly with infectious variants. And so my personal feeling is that the primary aim should be to make sure we're not getting severe disease causing hospitalization and death. If we do ultimately have to accept that COVID is one of the viruses that is around, and people are going to experience infection from. What we have to really focus on is making sure that the people most vulnerable to severe disease and ultimately, the broad population are totally protected from those severe outcomes. But at the same time, if we get, one of the things to really encourage high coverage is if we get there, and I think we're talking about 70% plus, ideally better than that in the adult population, then that will definitely have a dampening effect. I mean, that will definitely have an important impact, but it's unlikely to keep things at zero.
Will our intensive care units, when the virus comes back in, be overrun? I mean, what's the modelling suggesting on that?
Well, I'm not a modeller, but I guess I talk to a lot of modelers. We're about to see a big natural experiment in the UK, as some of you may have been reading in the media, that the UK, having got to sort of 80% of adults, is about to embark on a situation where they're saying, well, it's summertime, no masks, no social distancing, and we just try and mop up the remaining people that haven't been vaccinated. And so I guess we'll see how that goes. For the moment, it seems to be working reasonably well. And importantly, even with the Delta variant, the one that we're all concerned about because of increased infectiousness, amongst the vaccinated people, it doesn't seem to be really causing a problem. And the really fantastic evidence for that is this study the UK has had going for quite a while called the Siren study, where they enrolled healthcare workers now probably 6 or 9 months ago, and they've been tracking them steadily to see what happened in terms of ones who'd been infected, did they get infected again, and then more recently the vaccinated, which is now like 95% of healthcare workers, which is obviously what you want to see. And in that group, although they are seeing infections with Delta, they're not seeing anyone, getting anything approaching hospitalization. So basically zero. Although that group is obviously healthier. We're not talking about very frail or elderly people who are in that cohort. But that's still, I think, very encouraging news in terms of how things hold up.
Would it be fair to say that while the Delta virus transmits more quickly, it's not more lethal if you get it?
No, that's right. I think the evidence so far is suggesting that it's not any more virulent. You will potentially get, particularly in a non-immune population like New Zealand, you would potentially get lots of people getting admitted to hospital, even if that's a small percentage of the ones who are getting infected, if you've got a lot of infections. But I guess the UK experience, I guess you have to compare with India, where obviously it was a very large country with very few people vaccinated, and we saw the havoc that wrought. But in the UK, with very high vaccination, plus of course a whole lot of people with disease-acquired immunity as well. So when they're doing the sero surveys in the UK, they're getting up to numbers like 85% of people who've got antibody from either infection or vaccination, and that's the sort of level where you would expect to see, very substantial dampening down of transmission and real impacts. But I don't know that we're going to get. In fact, I'd be very surprised if that does mean it gets down to very low numbers, because they've just got such a lot of virus in the UK community.
Question here: if somebody had COVID positive, for how long should they have to have spacing before they get a COVID vaccine? Should they delay?
Well, I think the main thing there is that people are not unwell, because if you acquire COVID and you're early in the illness, then you could still get worse before you get better. So you wouldn't want to be giving a vaccine early and confusing potential vaccine side effects with disease. And I think the general advice is you want people to be fully recovered. And the good news, I think, is a lot of data is now emerging to say that if you have had COVID and recovered from it, and then you're vaccinated, that is a really very strong degree of protection, because you've had, I guess, exposure to all the potential antigens and epitopes and so on that the virus has to offer, and you probably develop quite a broad-based immunity to all of that. And if you then are specifically stimulated by, one of the vaccines like the Pfizer vaccine that we know works so well, then that is probably as good as you're going to get. I'm not suggesting that having COVID first is a good idea, but what I'm saying is that, if you're in that situation, there is a little bit of, gold at the end of the rainbow, if you like.
Yeah. I guess the other issue is this thing about spacing. There was a question before about there seems to be some evidence from overseas that the longer the spacing, the better the boost. Should we be moving to longer? I mean, I guess the other thing is, it's 3 weeks at the moment. We shouldn't, I guess, get worried if it's 4, 5, 6 weeks. Would that be a reasonable?
No, that's right. Well, those of us who've been working in vaccines for a long time, it's sort of, immunology 101 that a longer period between the first dose and the boosting dose is usually associated with a stronger antibody response. And of course, we've, moved to 2+1 pneumococcal schedules and 2 doses of HPV instead of 3, etc. So there's a lot of history with all of that, and that's what we would expect. And the difficulty with Pfizer is that, it was never done like that. The trial wasn't done like that. The idea was, this is a pandemic, we need to get people protected as quickly as possible, so we'll have the minimum interval, which was the 3 weeks. It always made sense that longer than that would be fine, and in fact might be better. And there is some data from the UK where they made that decision early on. They said, well, look, we've got a big problem. So what we want to do is just get as many people to have a dose, and particularly our high risk population, as many people to have a dose as we can, and then we'll worry about the second doses later. And they got a lot of flack for that. A lot of the US people were not happy. They said, look, that's not the license thing and you can't do that. But the UK went ahead and did it anyway. And so I think we've got good evidence from the UK that those longer intervals work just fine. The concern that some people have raised is, well, what about variants? If we don't get such a flash antibody response after the first dose, does that mean you're likely to sort of be susceptible to a variant or encourage variants? And I don't think we've got any evidence to really support that concern. But by the same token, it probably doesn't make sense to stretch out the doses endlessly. But Bruce, I think the Pfizer product information actually says up to 6 weeks is okay. So that's what's gone to MedSafe. And so you're on very safe grounds in that kind of 3 to 6 week gap. Although I think, and Joe can, chime in here, but my understanding is that the ministry is quite keen, where possible in terms of scheduling and arranging things, to stick to the 3 weeks and to keep that message, just in terms of, keeping people going through the doors, but recognises that if people, for whatever reason, are not having it in 3 weeks, that's okay. We're certainly not talking about extra doses or anything like that. You just carry on from where you started.
Joe, do you have a comment on that?
Yeah, no, that's exactly where the position is at the moment, that people are encouraged to have their second dose after 3 weeks or as soon as practically possible after that. But there is no sort of end date. You don't sort of start again. In terms of measuring ourselves to see how effective we're being in ensuring people have a second dose, we measure that at 6 weeks after the dose.
Question here, but I understand in Israel they're already talking about booster doses for immunisations as immunity is waning, particularly with the new variants arriving. Is this correct?
Well, I think it depends on immunity to what, and I think there has been a lot of confusion about that. And it's protection against what, and it's immunity to what. So the early trials, because they were mostly with young, healthy people, they were looking at any infection, and particularly any infection with any symptoms. And that was what the great majority of cases were. There were very few cases in the trials where people were sufficiently ill to, be what would be described as critical in hospital, ICU, etc. So the information from the trials didn't really give us much information there. And there's still confusion about this, that it looks, the evidence looks very strong that even though your antibody level might be pretty ordinary, and to be honest, the responses to the Chinese vaccines, which is just the whole virus, the antibodies don't look that great, but they do seem to protect you against severe disease. But that low level of antibody, which is quite enough, particularly combined with T cell and other immunity to protect you against severe disease, will probably not protect you nearly as well against an infection. So, and that's where the UK is seeing this, experience with healthcare workers who are obviously exposed to a lot of COVID patients, that they may develop an infection with Delta, but they're not getting sick. Of course, compared to what was happening before the vaccines, there's a lot less infections. But the whole booster thing, a lot of people think is a little bit premature, because firstly, we're still trying to get doses into people who haven't had them. Particularly on a global scale, we're trying to do that. And secondly, I don't think we really have any evidence so far to say that a booster is necessary, this long or in these people. We'll accumulate that. But going forward, the question will be, well, are we comfortable if people may not be protected against any infection, but they're not going to get sick from it? Or do we really want people to be protected from getting any kind of infection, as much as we can? And that also is a point, that Joan was raising with the HIV community and others with compromised immunity. That would probably be the group that you'd really focus on first in terms of boosters. And there have been some studies of renal transplant patients and other similar groups in terms of additional doses. That's probably where you go first with this. But I don't think we get carried away with saying, our antibody levels are going down, we all have to have boosters, because, that's only one indication of your protection. And it sort of comes down to, well, what are we trying to protect against?
Okay. Got a couple of questions about ivermectin. Does it reduce immunity, reduce severity, and is it effective in treating COVID? One of the pharmacists had that question.
Yeah, well, I'm a fan of ivermectin. I had an anecdotal experience some years ago with the last HIV patient I was looking after, who I saw him the day after this happened, but he had actually shaken hands with Princess Diana, but it turned out that he had Norwegian scabies at the time, and ivermectin fixed that up. But as far as ivermectin and COVID is concerned, look, there have been a lot of trials. There's a lot of studies. They're mostly small studies. They're mostly not very good quality studies. And the most recent one that was published in JAMA a few weeks back, looking at the other end, which is, does it help you against, developing symptomatic infection from ivermectin? Does it work there? The answer was no. There was no difference between the treatment and control groups. And there is a kind of WHO sponsored group looking at therapies and kind of systematically reviewing all of them. And it's all appears in the BMJ every kind of 3 or 4 weeks. And so far, ivermectin isn't out of, it's not off the list like chloroquine is, but it's not on the list either. So, and it certainly isn't approved for that indication in New Zealand.
I looked up the MedSafe stuff, and I was surprised at the lack of data about adverse effects, because I don't know if the audience knows, it's actually used in sheep for sheep drenching, I think, in New Zealand is its major use, but not that should put us off for human use. But I was just a bit surprised. Usually medications, I just wondered if there hasn't been that much human use.
Well, ivermectin has been brilliant also with scabies, of course.
Yes.
There's been some big studies both in Australia and the Pacific showing just how good it is in that situation. But so I don't think we have to worry too much about safety. It seems to be reasonably good from that point of view, but just how well it works against COVID, I think the jury is still out.
Right. Okay. So there's just some organ. So one of my patients had severe acute labyrinthitis after the first dose and had to attend A&E. He is reluctant to take his second dose. What would be your advice? Is it okay for him to take the second dose?
Yes, well, there's been a few queries like that coming through to IMAC, and it does look like, I mean, it's definitely a thing. And Nikki Turner, who obviously, has much more experience in that kind of general practice environment that I'm not familiar with, was saying that it's something that she's definitely aware of in terms of other vaccines as well. And so people who are prone to labyrinthitis certainly, could have that brought on. But I think the general view is that it's not a contraindication to a second dose. It, obviously it's going to require discussion and reassurance for that patient. But unless it was really extreme, I don't think there's any view that it's a contraindication. And just whether it's kind of the COVID vaccines are on the list of a whole bunch of other things that could make your labyrinthitis worse, or whether it's a specific causal connection, I think the jury's still out on that as well.
Yeah, a bit of a funny thing. Someone has chickens and hedgehogs with mange, and they'd like some spare ivermectin. So we will have answered that question, I would say.
Right.
Maybe a question for you, Joe. Is the CRI going to be built into the MPS like MedTech?
So there are ongoing discussions about what sort of level of integration we can get between the CIR and all PMS systems, not just MedTech. Technically, it is challenging, and what we're really looking to do is to future-proof it. Some people have asked why we're not using NIR as the database for vaccinations, but NIR was very much at the end of its lifespan and simply would not have coped with the volume of vaccinations that are being recorded now, hence the new system. So at this point, I can't promise the level of integration there's going to be between the CIR and the and general practice patient management systems, but what I can say is that we're working as hard as we can to deliver a degree of integration, which means that it won't add lots of unnecessary time when people are being vaccinated in general practice. It is a work in progress, though.
Well, I think it's fair to say this whole COVID business, the public health people describe it as building the plane while you're trying to fly it at the same time. And I think that's quite a good analogy. So we're taking questions for Professor Peter McIntyre, who's one of Nikki Turner's Type 5, I think they sort of call you, Peter. You're 5 experts, Joan Ingram, I think yourself, Michael Baker and Nick Wilson. Is that the group?
Yeah, well, Michael and Nick are, esteemed colleagues, but they're not part of the IMAC immunisation advisors. The other ones are Emma Best and Edwin Reynolds, along with Joan, Nikki and myself.
Right. So got a question here. GBS, thromboembolic, Bell's palsy, others. What do we tell patients if they ask about possible side effects? Do we mention these? My understanding is for side effects more than 1 in 10,000, you're not obliged to mention it. I don't know what your, if you know what the rules are on that, Peter, or what would you say?
Well, I think it's a doctor-patient thing in the end, isn't it? I mean, if someone specifically raises it, I guess you need to respond. As far as Bell's palsy is concerned, my understanding is, again, there's no definitive evidence of a causal relationship. Obviously, in every vaccine trial, Bell's palsy turns up because it's not super uncommon, and so it's there. GBS, I'm not aware of any evidence to support that, but if you immunise enough people, some of them will get GBS. What was the other one, Bruce?
GBS. Not sure what they mean. What's GBS?
Guillain-Barré.
Oh, Guillain-Barré. Thromboembolism, Bell's palsy.
The embolism, yeah, well, the clot one, of course, has been huge in Australia because they were using the AstraZeneca vaccine. Been a huge issue. I mean, the positive spin I put on that is that, it was a new syndrome, it was an unexpected syndrome, and despite that, and despite its rarity, it was picked up very quickly. The clinical course and appropriate treatments and so on were worked out very quickly. And although potentially is still fatal. I think people now understand it a lot more and can treat it. The current feeling with the AstraZeneca or the current data is it's probably something like 1 in 30,000, which is not nothing, but is still, quite uncommon. And one of the questions that is unanswered because there haven't been nearly as many doses given is the Janssen vaccine, which is also a adenovector vaccine that is likely to be approved or may have already been approved in New Zealand. And so it may be one that we have, up our sleeve, that will obviously be a little bit more in the spotlight in terms of possible thrombosis because it's an adenoviral vaccine and there have been some reported cases. It's just not totally clear whether it's as common as it is with the AZ. Understanding the AZ is rare. So the whole
embolism, that's not with the Pfizer vaccine. That's just the AZ vaccine.
Yeah, well, it's confusion because the vaccine trials look for thromboembolism of the usual kind, and in fact, particularly because COVID itself obviously causes a lot of thrombotic phenomena. Actually, looked in much better shape with the vaccine than without it, as far as thrombosis was concerned. But the specific syndrome is getting thrombosis usually in funny places in large veins like the cerebral venous sinus or the splanchnic veins, etc., and also getting thrombocytopenia at the same time, which is the sort of heparin-related HITS sort of syndrome, which those who use heparin quite a bit, which doesn't include me, were quite familiar with. So it seems to be, it's this, quite unusual but quite definite vaccine-related thing, but it's not like thrombosis in general. It's not your DVTs and your pulmonary emboli. It's a specific syndrome.
So this was the AZ vaccine, is that
That's
right? Not the Pfizer one. So,
I mean, Pfizer, there's been a bit of talk about thrombocytopenia with Pfizer. There have been a few, but certainly not thrombosis. Yeah.
Interesting. I mean, bit of good luck in choosing Pfizer, really.
Yeah, that's right. That's right.
More than good luck. I mean, was it well informed? I guess.
Well, I mean, I guess it looked like a strong candidate from the early results, with high efficacy and so on. And but I think the Australian decision to make AstraZeneca themselves and to potentially have this other one from the University of Queensland to be able to make domestically looked very smart at the time, but unfortunately just didn't quite pan out the way people had hoped. So Pfizer has I think been it's been a nice situation to be in. What can we say?
Yeah, no, lucky us.
Yeah.
Is there a correlation between better immunity uptake or protection and more adverse events and more severe? Why are our younger generation having more adverse events requiring time off work due to adverse events?
Well, the time off work thing is important to mention. I mean, the second dose of the Pfizer vaccine in a substantial proportion of people, so 20% or thereabouts, are feeling crook enough, with flu-like symptoms, myalgia, fever, headache, etc., to just not want to go to work. And I think we have to acknowledge that, and I think workplaces have to acknowledge it, both public sector ones and private sector ones, you would hope. But I guess the positive angle on that is it shows your immune system's really kicking into gear. And although I haven't seen any specific data to correlate this, I wouldn't be surprised if having that kind of very robust reaction also correlated with high protection. But I don't think we can actually say that at the moment. But certainly we can say, look, your immune system's in good shape. So good luck on that.
Would it be safe to giving mRNA vaccine to people with autoimmune disease?
Yes, the people who look after most autoimmune disease, which the rheumatologists and immunologists are all very comfortable that there's no contraindication. I mean, this sort of question came up with flu vaccine and are you more likely to get GBS, etc. And there's no evidence to support that. And I think the general view is that particularly people with various autoimmune diseases who are on immunosuppressant medications, in fact, really need to be, protected against COVID. It's important that they do receive a vaccine.
Got a question for Joe here. Are any of the current GP practices given COVID-19 delivering it to patients that are not enrolled at their practice?
Yes, so it depends on how they've been commissioned by the local DHB, but yet we have examples in South Auckland actually that NRHCC have commissioned. Highland Park was one which has collaborated with other practices in their area to vaccinate, and Matt can probably give more details there.
Matt, do you want to unmute yourself and perhaps answer that one?
Yeah, we've got a number of our practices that are vaccinating people that aren't registered or enrolled with them. And while others are prioritising their enrolled populations currently. But yeah, no, there's a number of primary care vaccination sites over Auckland that are enrolling both groups, vaccinating both groups.
Okay, a question from Chris. He's a urgent care doctor. Where can we go for advice to help work out if somebody who has a possible reaction to vaccine number 1 have their second shot? I saw an 80-year-old man with a widespread rash that looked like a drug rash and had a few mouth ulcers on day 4 after his shot. Honestly, don't know if he was okay to have his second. Any take us to that, Peter?
Well, if it came through to the IMAC 5, as you say, Bruce, we'd say yes, it's fine.
So IMAC would be a good place to go for that.
Yeah, but what we're trying to suggest is a lot of the more common questions, and I think the northern regional people have had a lot of experience with this as well, and it's happening everywhere around the country. I think the common questions that there are people locally who can, sort out most of those. Either, and there are probably different arrangements in different places, but IMAC is certainly happy to be involved if things are, been looked at locally and there's a bit of concern to say, oh, what do you think about this? Very happy to do that. But we're not encouraging everyone who's got a question about anything to come to us, because unfortunately there isn't quite enough hours in the day for that.
My understanding, people who have had an anaphylaxis to something somewhere else probably need to be well supervised. Is that correct?
Yes, well, it's suggested that they're in a situation where people are, obviously anyone who's delivering the vaccine program should be trained to and comfortable with managing anaphylaxis. But, I think particularly in smaller localities, some sort of local arrangement where what you really want is there to be comfort and confidence, in that setting.
Perhaps starting with an IV line, so you've got a portal of entry.
I don't think anyone's recommending that, Bruce. I think the idea is that you're perhaps just keeping them a bit longer, and being aware. But and one thing that I guess is a little bit tricky, and Joe might like to comment on, or Matt, with what's been happening with this locally is there can be an overcall problem, that people can have quite a lot of anxiety related, stress related sort of reactions, that can look quite alarming. And if someone reaches for the adrenaline, well, that doesn't make it any better. And then once that's happened and they've been given adrenaline, it can be very hard to sort out exactly what the problem was. So I think that's the tricky balance. We want to say, look, you are empowered to treat anaphylaxis, but we also don't want people giving adrenaline to every 10th patient. So it's that balance. I'm sure you've been having a lot of questions coming through, Joe, on these sorts of issues.
Yeah, and CALM do investigate all serious adverse events, and they have a process for triaging them, because there's obviously what's happened on this program is we've made it easier to report events as well. There's evidence that shows that if there are good reporting systems, it actually does build public confidence in a vaccine. But that's just a process that we're going through now with having easier reporting systems, is seeing people reporting things that we potentially hadn't been reporting before. So we're just working through that, but we know that the number of reports we're having in New Zealand are no higher than anywhere else in the world. Yeah, sorry, I'm trying to remember the first part of the question now, which has gone from my head.
About anaphylaxis, Bruce, was it? Or?
Oh, you were, yeah, and so when we are looking through, they do actually have a look and see whether it was true anaphylaxis and then provide sort of further comment. But that's really more from a pharmacovigilance perspective, rather than providing specific advice about individual patients.
Yeah, and I think CALM is very keen to make that distinction. So on the one hand, they want to encourage all of you out there to report anything that you think is of significance. But on the other hand, they're not in a position to provide clinical advice about, gee whiz, I think this person had anaphylaxis, what do I do? And there is quite a nice guideline, though, that's been, reviewed and I think is out there now, Joe, sort of covering that issue. And the kind of entry point, I suppose, is if someone saw fit to give you adrenaline, then you need to be reviewed and a decision made about, was it really anaphylaxis and what to do next? So that's a sort of entry point, if you like, for the discussion.
Might be a question here for Joe or Leanne or Matt. How do we find out where those practices are that will do non-enrolled people, not just their own patients? Anyone want to?
Yes, basically we have a NRHCC website and it was on the presentation earlier that we did, and that lists the GP vaccinating sites and the community pharmacy sites. Most of them are there. There have been a few practices that have asked not to be put up there because they're just feeling like they're a bit overwhelmed at the moment with inquiries, but most of them are up there, so you'll be able to have a look at those.
And moving forward nationally, we'll be working with HealthPoint to create visibility of sites that are available to anybody to come and book in.
Yeah, we are encouraging our providers to list on HealthPoint as well. So we are supporting them to do that as well. So yes, it's great if they can look there as well. And yeah, HealthPoint are being very supportive of that.
Okay, so we're going to go through to 9 o'clock with the questions. Some of you are starting to write very long ones. They're extremely difficult to answer. If you'd like to rewrite some of them a bit shorter, if you had more time, write a shorter letter. My mother told me that you had more time, write shorter letters.
Yeah.
Just they're almost impossible to translate, so I can make sense of it to the speakers. Is there any connection between mRNA vaccines and heart inflammation? Can you explain how these vaccines might cause myocarditis in teens? And are there any adverse effects reported in New Zealand? Maybe one for you, Peter.
Yes, no, a very hot topic. One which is being closely considered, as we speak. I mean, the myocarditis, pericarditis thing does seem to be in that, category of rare but definite adverse events, but this time with the mRNA vaccines, not with the adenovector ones. Interestingly, if you look at myocarditis, pre-vaccines or myocarditis, that we're used to seeing, then it also has this characteristic that for some reason other adolescent males are much more likely to develop it, whereas in pre-adolescent children it's rare and it's the same in boys and girls, and then in once adolescence is reached and young adulthood up to the age of 30 really, it's much more common in males, and the syndrome that's been described with the mRNA vaccines, and it's both the Pfizer but also Moderna in the US, seems to be within 4 or 5 days of receiving the vaccine, be associated, the sort of things that present chest pain, sometimes shortness of breath, sometimes things like palpitations and so on, and most of them, although they, because of the fact that it involves the heart, that pretty much everyone gets hospitalized, but almost everyone seems to get better quite quickly. And there are very few examples of long-term problems, although it's still early days in terms of working that out. But overall, the feeling is that yes, it's definite. Yes, it's rare, probably in the same ballpark, or maybe a little bit more common than with the clots that we were talking about. but not nearly as severe as the clots. So we're not talking about risk of death, although that's something that you'll be worried about. But in the US, they, given how much COVID they've got, they've been very clear that this is something which needs to be noted, but is not, that the benefits of vaccination far outweigh the risks. In the sort of New Zealand setting of no COVID, it obviously becomes a little bit trickier in terms of the messaging. And one of the things which I guess people have been thinking about also in Israel, where it was, perhaps first came to light with a lot of young people getting vaccinated, is, could you actually make do with one dose in a younger person who gets very strong antibody responses? So I don't think we know at this point in time, and it will be important to get the messaging right about, on the one hand, being transparent that yes, we recognize this, yes, it is real, but it's also, for the most part, not severe and is very uncommon. And we're not seeing it as a barrier to getting vaccinated, but it is something that I think, in the interest of transparency and safety, we have to be frank that it is something which has emerged, but something we don't believe is going to be nearly the problem that the thrombosis was.
So how would you diagnose it? Would it show up on an ECG or troponins?
Yeah. Well, interestingly, there was this study that was done of smallpox vaccine back, in the Desert Storm days with young military recruits, and they had about 1,000 people who got smallpox vaccine, and they did. I don't know why they did this, mind you, but they took clinical histories, they did troponins, and they did ECGs serially for a couple of weeks on these people, and they did actually identify about 5 instances of myocarditis based on ECG and troponin, but actually 3 of the 5 that they found wouldn't have come to light. They wouldn't have reported, to anyone as having been ill, if they hadn't done all this testing. So maybe it's more common than we've been recognizing, and possibly happening with other vaccines as well. But it does seem to be something specifically with the mRNA vaccines, and it is a communication issue which is going to become more important, obviously, as we're getting down to that group 4 and the younger male recipients.
Okay, just got a sort of more medico-political question here. Does anyone have concerns about the guidance statement from the Medical Council effectively muzzling any doctor with concerns regarding the vaccination program? Makes it difficult to have a robust debate in a safe environment. So maybe any of the panelists might want to take it, but do you want to take that one first, Peter?
Well, I think as long as that isn't being used as cover for talking about, a whole lot of, discredited theories. I've seen some stuff produced by a group that call themselves New Zealand doctors, and most of the stuff that they've trolled up are actually old stories about, and completely false stories about vaccines that have been around for a long time, including things like, infertility and, infection of others with, vaccine material, et cetera, all of which is completely erroneous. So I think the material that we've seen from that group, to be perfectly frank, is not worthy of any kind of debate. But I think the myocarditis issue and risk communication about that is something which clearly, as doctors and responsible doctors to our patients, would all want to be on top of and having the right communication messages about. So I suspect what the Medical Council is saying is, that the very important point that someone who's got medical qualifications and is out there spruiking nonsense is a big danger. Because unfortunately, that medical qualification gives you a lot of credibility, which, your assertions may not justify. So I think that's what the Medical Council is concerned about. I don't think they're concerned about genuine questions, concerns and issues raised.
No, I'm aware of one colleague who raised the issue of genetic modification. I thought, well, that's a misunderstanding of how mRNA vaccines work, just because it's mRNA. Joe, do you want to maybe have the final word there?
Yeah, I just wanted to make people aware that there is an independent vaccine safety monitoring board as well. So that's independent of the program. Obviously, working in the program, we've been very close to it, and keen to progress as quickly as we can. So an independent group has been set up, and they review everything from outside of government and outside of the program to ensure that any feedback that we're getting that is questioning the safety of the vaccine is considered in an open way. So I think if any of our colleagues are concerned, they should be encouraged to go through those channels. But as Peter was indicating, supporting theories that have already been disproved in a public forum is exceedingly unhelpful.
Yeah, no, good. Well done, team. Okay, well, I'd just like to, so it's 9 o'clock now. So I'd just like to thank Matt and Leanne and Joe for the first half, and Peter and Joe and Matt and Leanne for the second half, our game of two halves. Really appreciate that. I'm always amazed how many questions. We wanted to have a general Q&A, but the questions just keep coming.
And thank you
thank
you also, Bruce, to the audience for the a lot of the excellent questions. They really help people like us who are doing a lot of it. A lot of thinking about this to, sort of make sure that we're keeping on top of things. So thanks very much for that.
Probably need to have little regular COVID webinar for those interested, because clearly there's a lot of people interested. So we had 800 people sign up for tonight. So, so thank you very much. Thank you very much to the audience, and to our Paul Keogh, who's behind the scenes and always makes sure these things run very smoothly. This is being recorded and will be available on the Goodfellow site. So if you want to see it, and you will get an email from us with the slides and the links. And thank you very much. So over and out. Good night, everybody.